Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gaulin.
Hey everyone, welcome to this episode of the Gastro Girl podcast. This is a special episode geared towards our providers and clinicians who are diagnosing IBS with constipation. And today we're joined by the amazing clinician Kyle Staller, who's a gastroenterologist and neurogastroenterologist. And he's also the director of the GI Motility Lab at Mass General. Welcome, Dr. Staller. So happy to see you on the show today.
Jackie, thanks so much for having me. I'm excited to be here.
Great. So just for those who, just to kind of set the tone, can you give a brief overview of IBS-C and how it fits into the spectrum of IBS subtypes?
Sure. I think we should start with irritable bowel syndrome in general, or IBS. And essentially you have abdominal pain. You have to have abdominal pain. And that's associated with a change in bowel habits. And by a change in bowel habits, that means a change in the frequency of stool, a change in the form of stool, and an association of the pain with defecation. And this definition has really evolved over time, right? Before, this was sort of considered a disease that may not be taken so seriously. And over the subsequent years, we've realized that, of course, it is a real disease. It deserves respect. And our definition has sort of evolved with that understanding and the more that we learn about it. So the most recent definition, as I said, is pain associated with a change in bowel habits. And the spectrum of disease can be on one side, diarrhea, which is sort of the looser stools, what we call the Bristol type 6 or 7 on the Bristol stool scale, that lovely stool scale that everyone should have in their office because it's so helpful. And then we have IBS with constipation, and those are the harder stools, the hard lumpy stools, which are Bristol type 1 and 2. So if you have more than 25% of the loose stools, then you're IBS-D or diarrhea. If you have more than 25% of the hard stools, then you're IBS-C. And if you're unlucky enough to have more than 25% of loose and more than 25% of hard, then you're IBS-M or mixed. And so today we're talking about C, which is the constipation subtype. And so we say abdominal pain associated with bowel habits. Interestingly, the definition changed in 2016. It used to be abdominal pain or discomfort. And now we sort of said it's abdominal pain only, and you have to have it at least once per week. And in some ways, I think it did our IBS patients a disservice because it took patients, about 12% of the world had IBS. Now we changed the definition. Now it's about 6%. But all those patients that only had discomfort and didn't have pain probably still have IBS and would benefit from some of those same treatments, but now they're not being counted. So I look to see the definition, which we're going to be having coming out in 2025 with the Rome 5 criteria, the Rome criteria, how we define IBS and other disorders of gut-brain interaction. Those are going to come out, and I think we're going to walk back some of those changes that we saw most recently.
Interesting, because that's my next question has to do with the diagnostic criteria and symptom evaluation. So I know the definition is changing, but for now, can you walk us through the Rome 4 criteria for IBS-C and how do these criteria help providers in differentiating IBS-C from the other subtypes you just talked about or other disorders of the gut-brain interaction?
Yeah, so right now our definition is essentially that you have to have abdominal pain. And that abdominal pain needs to be associated with basically 2 or more of the following, right? A change in the frequency of stool, so how often you're moving your bowels, a change in the form of stool, meaning you're having harder or softer stools, and there has to be a relationship with defecation. And many people sort of have that common misconception that your defecation needs to improve your symptoms, and it's just that they're associated. So defecation may make your symptoms worse. And this has to be chronic. It has to be going on for at least 6 months. And in the last 3 months, you have to have these symptoms at least 1 day per week. So that's the official criteria that we use when we enroll patients in clinical trials. But there's really a clinical criteria which requires sort of a little bit less of the frequency. It doesn't need to be so dogmatic because if it sort of looks like a duck and it walks like a duck, it's probably an IBS-C duck. And I think it is important that we don't get overly stringent on the criteria, but realize that those stringent criteria are how we enroll people in clinical trials. Now, the hard stools that are part of this, right, that is really in IBS-C specifically, those are Bristol type 1 and 2. So verbally, right, it's sort of a lumpy sausage, or it is small, discrete pebbles, what I call rabbit pellets for my patients. These are the types of stools that need to predominate at least 25% or more of the time in order to fall into that category. And so if you use those criteria, you can very easily, and there's even, online MD Calc or other things if you wanted to put it into some sort of algorithm. But you just sort of remember those types of things. And then, the real difficulty and really maybe a controversy is differentiating your IBS-C from your chronic idiopathic constipation, which we can talk about more as well.
Yeah, that was my next question, actually, for providers. And patients are frustrated too, because they're trying to figure out, there's IBS-C, there's functional constipation, or just constipation, chronic idiopathic constipation. So what symptoms, and I know you kind of touched on this with the pain, but what symptoms should providers focus on when diagnosing IBS-C and distinguish it from these other conditions, and then explain it to patients? Because that's what's so, I think, frustrating on both sides.
Yeah, it's really acronym city, right? You have IBS-C, as you mentioned, you have FC or functional constipation, you have CIC, you have IBS, I don't know what it is, right? So all these patients, the poor patients, they hear so many of these things and it gets them confused. So we talked about the definition for IBS-C. Now we have sort of functional constipation. That's the Rome name, which is where we kind of get the classification for symptoms. And functional constipation essentially says you have to have two or more of the following, right? Decreased frequency of bowel movements, hard bowel movements, straining, a sense of incomplete evacuation, a sense of anal rectal blockage, or manual maneuvers to facilitate defecation. So if you have two or more of any of those, you fall into the functional constipation category. And that assumes that you don't meet criteria for IBS-C, which means functionally you don't have pain. So pain is really the differentiator between the functional constipation and the IBS with constipation. Now, we say CIC, and I find myself lapsing into chronic idiopathic constipation. That is what the FDA, right, the Food and Drug Administration, defines as functional constipation for the purposes of clinical trials. So I tend to think, and I think probably popular-wise, we tend to say more CIC or chronic idiopathic constipation. That tends to have more pull than functional constipation for whatever reason. But, think of functional constipation and chronic idiopathic constipation on one side of a spectrum, IBS with constipation on the other side of a spectrum. And the differentiator, the slider that puts you in one or the other, is abdominal pain. So when I see a patient and they talk to me about pain, I'm putting them into the IBS-C bucket. When they're saying all of these other symptoms, but I say, do you have pain with your bowel movements or when you're constipated? And they say, no, it's discomfort. That's going to be in the CIC or the FC bucket. The truth is that I think many of us in the field really think that these entities overlap a lot. And it may be a little artificial to put one person in one bucket and one the other, when the next day when you ask them, they might say that pain is bothering them. But then the next day they say bloating, but not pain. So in reality, my toolbox, when I'm thinking about how I'm going to treat these patients, really takes the best of both worlds, because we have so many great pharmacologic options. We have biofeedback options, pelvic floor options. We have so many different treatments that I really hate to restrict to one or the other for the pure sake of semantics.
No, I love that you're expanding on this and really clarifying, because it does make sense. How do motility tests, if at all, play a role in diagnosing IBS-C? Are there specific tests you recommend to help differentiate it from other motility disorders like gastroparesis? Is there like a chicken and the egg? Does something cause something else? And this makes it even more challenging, I would think, for clinicians.
Yeah, I think it's actually a great question. And the reason it's such a good question is that IBS-C fundamentally is about abdominal pain, but at the same time, there is constipation, there's hard stools. And hard stools, the reason this Bristol stool scale is more than just something that's fun and something that you can put on the back of a t-shirt they sell at Digestive Disease Week, is that it actually is a surrogate for how fast things are moving through the colon. So when you have hard stools, things are moving through the colon slowly. When you have loose stools, they're moving through quickly. So a patient can be constipated without hard stools, but they don't necessarily need a laxative to speed things up. Now, keep in mind, then the stool moves through the colon and it gets to the end and it's sitting in the rectum and it's got to get out the door. And I always tell patients, imagine you have someone in the room you don't like and you're trying to push them out the door. Two things have to happen, right? You got to give them a good push and the door has to open. And so the push is the rectal or abdominal push, and the door opening is the anal sphincters relaxing and the puborectalis muscle relaxing to allow stool to come out. When that doesn't happen in a beautiful synchrony, then we have rectal evacuation disorders or pelvic floor dysfunction. And that can be part of IBS-C, or it can be part of CIC or functional constipation. So in reality, I think for many patients who are struggling and maybe their bowel habits have been addressed by their doctors, they're still having symptoms. Well, what's going on? Well, we haven't thought about the pelvic floor. And the pelvic floor has a big implication on symptoms in all of these patients with constipation. The other thing that's really interesting about the pelvic floor is that when the pelvic floor is malfunctioning, it probably causes a reflexive slowing of the rest of the colon. So, it's like a factory, right? If you can't get stuff out the factory into the loading dock to send it on to the stores, then you're going to slow down production. And so probably what happens is people can have a responsive slowing of their colon because their pelvic floor is not working. And so it's really something that's often missed. For me, it's always exciting when I have a case of refractory IBS or constipation and no one has looked at the pelvic floor because it's easy, right? It's a low-hanging fruit. Now, how do we do it? Well, that's where the motility lab world comes in, is that we do something called anal rectal manometry. And of course, in GI, this is probably something that doesn't really raise any eyebrows. But in general, right, we are going to insert a catheter into someone's rectum while they're laying on their side and have them simulate defecation. That's going to be followed by putting a balloon the size of a stool filled with warm water into their rectum and having them sit on a toilet and try and get it out within a certain amount of time. Not your typical Tuesday night, maybe, but something certainly that helps us really define who are the patients who would benefit from pelvic floor treatment. And the reason we don't send everyone to pelvic floor treatment is, one, it is an intimate type of treatment, right? There's going to be a process involving your pelvic floor. It's going to be somewhat uncomfortable. Two is it takes multiple sessions. It can have a time and a cost associated with it. So we really want to try and identify the patients who would most benefit from pelvic floor physical therapy and biofeedback. And we do that through anal rectal manometry in the motility lab.
No, thank you. That's very interesting. Now, for those who may be primary care providers listening to this or newer gastroenterologists, are there any other non-invasive tests like blood tests or stool tests that are useful in diagnosing IBS-C? And if so, how reliable are these tests in a clinical practice?
It's a great question, and something I didn't mention earlier, which is that these criteria, the Rome criteria for IBS-C, assume that there are no alarm symptoms, right? So a patient with IBS-C should not have bright red blood per rectum. They should not have weight loss. They should not have anemia. They should not have a family history of colon cancer, right? These are all things that sort of say, go back to start, rethink this, and maybe do an evaluation as appropriate. And I'm sure many of our physician audience will say, oh, yeah, obviously, if they're bleeding, then we need to do a colonoscopy. And that's certainly the case. But assuming you don't have any of those alarm symptoms, really the current guidelines, which I agree with, are that you actually don't really need an extensive workup to make a diagnosis of IBS-C. It is a historical diagnosis, right? If a patient meets criteria, they don't have alarm symptoms, your job should be spending less time ruling out, telling the patient what they don't have, and giving what we call a positive diagnosis, telling the patient what they do have. And I think one mistake that providers can make is so often they'll say, oh, okay, they know that you have IBS, the patient has IBS, but they really want to say, well, let's rule out this, let's rule out this, let's rule out this. And then finally, the patient has had a variety of tests and they say, well, we know you don't have anything bad, you just have IBS-C. And I think in some ways that's relieving, right? You don't have anything bad, but it sort of discounts that IBS-C still has a big impact on our patient's quality of life. And so just IBS-C is not just IBS-C. It means, no, you do have IBS-C. This is great. Let's start thinking about treatments that are evidence-based that can help people feel better. And I think we spend too much time kind of ruling out, and we should really make a positive diagnosis. Now, in that positive diagnosis role, right, I tell patients it's not that just you meet criteria. It's also, what does IBS-C mean functionally, right? It's not just, okay, you meet criteria, you don't have other things. It's really that there is a disorder of gut-brain interaction. You think of the gut, it is a massively innervated organ, right? It has more nerves than the spinal cord. And those nerves are all conspiring against you by sending abnormal signals up to your brain that are telling you that you have pain and discomfort. And your brain is fine, right? It's just getting bad data from its gut. And so now you're experiencing these pain. And then, of course, the brain can send signals back down that can amplify the pain and change the bowel habits. And so I think anytime we explain to a patient you have IBS, it shouldn't just be that you have IBS and you don't have these other things. It should be you have IBS and this is how it works. And when a patient knows how it works, then they become a partner with you in sort of this journey to figure out how to make them better.
I'm so glad you mentioned that. Coming from a patient perspective, I can't tell you how many emails and comments we get about the journey to get to a diagnosis. And I love that you say, oh, just, because to a patient, it's not just. It does affect their quality of life. And to have a positive, even if no one wants to hear they have something, but to actually have a positive diagnosis, and then this is how we're going to treat it, it does add to a sense of relief for patients that they know that they're going to be on a path towards getting treatment and finding symptom relief, instead of being like, oh, well, you don't have all these other things. And this is like, it's just this. Because to a patient that's struggling with that pain and struggling to have a normal bowel movement, whatever that is for them, it's not just.
Yeah.
So thank you for that.
Thank you. I mean, it has a profound impact on quality of life. And there have been studies that show that patients with IBS, particularly moderate to severe IBS, really have, decrements or decreases in their quality of life that are on par with a lot of the, quote, real diseases, right? And so, I tell patients, you're never going to die from your IBS, but it might make you want to kill yourself, right? In the sense that it affects your everyday and it impacts the way you live your life. And so the other piece that I think can be really helpful for patients, aside from really going after IBS-C specific treatments, is the educational component to explain, how do the brain and gut interact? Why does stress potentially make symptoms worse? Just because stress makes your symptoms worse, that doesn't mean that your disease is any less important to be treated or considered a disease. These are all the things that on their own can, I think, have a really therapeutic effect for our patients, all the while we're treating some of the things that maybe they thought they were needing treatment for, which is the constipation, the straining, those types of symptoms.
Yeah, I'm going to ask you to elaborate on that in a minute, but I want to go back because I wanted to ask you about the patient history, because I think this is a critical point. How important is this detailed patient history in making an accurate IBS-C diagnosis? And what are are there specific red flags that providers should look for during the exam?
Yeah, I think the big red flags, to answer the second part of that question first, is that, what we call alarm symptoms, bright red blood per rectum, dark stools, weight loss, anemia, family history of GI cancer, is particularly colon cancer. These are all things that should give us pause before we make a positive diagnosis, as I mentioned, of IBS-C. But I also think that the history itself, right? This is a historical diagnosis. When patients come to me in the office, if I'm doing a good job, I let them talk first, and I really let them elaborate on what their journey has been. And I think importantly to that, right, that allows them, one, there's a therapeutic value that someone is listening to them, because I think so many IBS patients have been dismissed by medical providers at the level of primary care, at the level of gastroenterology, by their family, right? We know that patients with IBS have internal stigma that they feel like maybe their disease isn't worth bothering people about. So giving them sort of that space to explain what's going on. And then the criteria are not too hard, right? You rule out alarm symptoms, and then you say, okay, how often do you have pain? Does it associate it with your constipation? Does it associate with harder stools, or how often you're going? Does it associate with when you move your bowels? Are you having it to some degree of frequency and it's been going on for some time? This is important. And I do think in many ways, IBS patients are wired for sensitivity, right? They are wired internally to be sensitive. And so many patients will tell us that they've had a history of some bowel symptoms dating back many years. Now, those might not be the IBS-C criteria, but they said, I've always had a sensitive stomach, but now it's bothering me. Or I've always had a little bit of diarrhea when I'm anxious, but now I'm really constipated and uncomfortable. And that, I think, can be another non-criteria history that's very important in my view. Because I would say when I have a patient who, let's say, is in their middle age, and they're saying, you know what, I've never thought about my stomach any point in my life. Suddenly, I have symptoms that meet criteria for IBS-C. That's going to give me pause and say, let's just make sure that we're not missing something else, because the criteria are quite good. You're going to mostly see IBS patients in your office when you fulfill those criteria. But some patients are going to meet the criteria and will have other things. So I have my antenna up when someone has brand new symptoms that they've never had any GI symptoms before, and it's happening later in life.
No, thank you for that. I also wanted to ask you about the role of the digital rectal exam. Does that have a place in the diagnosis of IBS-C?
Yeah, thank you. I think it does have a place, but it only has a place if you use it, right? And it's one of those things, if you don't use it, you lose it. So a digital rectal exam, it shouldn't just be, I'm looking for blood on my finger, right? It should be having a patient simulate defecation and think of your finger as a sophisticated probe that is going to measure the relaxation of the anal sphincter, the push from the rectum. And really that will help you identify patients who would benefit from maybe going further testing, right? So for providers who are listening or watching, who are from further afield, where testing at a motility lab like we have may be a bigger deal for their patients because they have to travel. A digital rectal exam can be a nice rule out. A digital rectal exam is kind of artificial, right? You're laying on the table. You have some stranger with a finger in your bottom, and you might have a chaperone, right? This is not every day.
Right.
So a patient who performs really well in that artificial environment, that can be a nice rule out test that sort of says, okay, this is a patient probably where the pelvic floor is not a problem. And therefore, maybe I'm not going to have them drive however many hours to get that motility test. On the other hand, many patients, either because they have a problem or because of the artificial nature of a rectal exam, are not going to perform their best. There's going to be evidence that synchrony between the push and the relaxation is not there. And those are the patients that I say, you know what, it's still worthwhile to move forward with additional testing.
Do you have any suggestions for providers on how to suggest that type of exam to a patient to kind of ease their fears and misperceptions about that exam? I know it's so important.
Yeah, I think there are so many patients, where I've seen them as maybe a second, third, fourth opinion, and they've never had a rectal exam, and it blows my mind. I think part of it is because it takes time, and right, physicians, providers in the community are increasingly rushed. Secondly, it's intimate, and it's something that you kind of have to broach with your patients, some of whom may have history of trauma and things like that. So I think it's essential to sort of say, the last part of our exam is a digital rectal exam. This is really important because how your pelvic floor works can be really associated with some of your symptoms. And this can be a first pass to see whether you might benefit from some treatments that are really targeted there. And then I will always have a chaperone, right? Both for my protection and for my patient's comfort. And then I will talk them through everything that I'm doing, right? This should not be, lay on your side in an exposed, vulnerable position, and someone is going to do something to you that you don't really understand what's going to happen. It should be like, first, I'm going to do this. Now you're going to feel this. Now I'm going to ask you to do this. And I would say I have a very typical script that I go through with every patient, and it doesn't vary much at all unless there's something special about their exam that I need to look at. And, when you hone that script, it becomes more comfortable. And I always tell the fellows who are learning gastroenterology, I would say, if you're not comfortable with the rectal exam, your patient is going to know it, and they're going to be uncomfortable as well. So you need to learn to love the rectal exam, because when you love the rectal exam and the great information that it tells you, you are then going to be able to convey that confidence to the patient so that they feel they're in good hands and you're doing something that's going to be helpful to them diagnostically.
That's very true. And thank you for that. So to go back to what you were talking, you started to talk about the gut-brain interaction. How do psychological factors influence the diagnosis and management of IBS-C? And how should providers assess this connection in their patients?
I think it's an important question, because I think that we know that patients with IBS-C often have pre-existing conditions that are psychiatric or psychological, like anxiety or depression specifically. And I think because of that relationship, there's a tendency to minimize IBS, to sort of say, well, your symptoms are in your head because you have too much anxiety or because you're depressed. And I think there was a great genetic study that looked at the genetics of patients who had IBS and had anxiety or depression. And what they found is that there's a huge overlap of patients who have both IBS and anxiety and depression. But when they looked at patients who only had anxiety and depression, or only had IBS and didn't have the other, they found that many of them shared some of the same genetics, which tells us is that these patients who are prone to anxiety and depression are also prone to IBS, probably because they're wired in a certain way. Okay. And I think it's important to say is that means that anxiety and depression are not the cause of your symptoms. They are something that can often go together. And I always draw a picture of like an intestine with these wires that go up to the brain. And the wires are the malfunctioning part in IBS. And so your brain is getting bad data. And in many ways, your brain is able to filter out that bad data and suppress it and say, that's kind of junky data. Let's keep that quiet. But when you're under stress, when you're under anxiety, and it's particularly like chronic stress, right? A bad marriage, financial difficulties, these kind of things that kind of hang over you like a dark cloud, your brain is less able to filter out this abnormal signals from your gut. And that's why when you're under stress that your symptoms get worse. It's not because your symptoms aren't real. It's just because your brain is less able to filter things out. And I think that's an important message for patients. Now, at the same time, many patients have had trauma, right? And particularly patients who show up at a place like Mass General where I work, these patients in a tertiary referral center are much more likely to have experienced trauma that may be childhood, physical, sexual, emotional abuse. And your nervous system is developing during that time, during childhood, even up into your 20s. And so you can imagine if you're unfortunate enough to experience a trauma during that time, that maybe your nervous system will develop in a slightly abnormal way such that it becomes hypervigilant, right? It's now looking for trouble. And so many patients, I will ask them about trauma. That's controversial in our field. Some providers would say, don't ask unless you're ready to deal with the consequences. Others would say it's an important part of the makeup of our patients because many patients want to know, why me? Why am I the one here with IBS when my person next to me doesn't have it? Sometimes, a history of trauma can change the way the nervous system develops, and that may be a predisposing factor in people who otherwise have some other predisposing factors as well.
No, that's really important to note because I get so many, again, patients write us all the time, and I get so many, just heartfelt emails about that, the trauma, and they say, why do I have this? And it is an important piece. So if providers that are listening, it is very important from a patient perspective to pay attention to that. And it helps the patient understand the root or potential root of why they're having those symptoms, because it already is a little ostracizing for them to have those symptoms and then to not understand why they have them.
Yeah, exactly. I think it doesn't mean that we're not going to treat the symptoms with, treatments that may make you go to the bathroom more often, right? That's still part of our treatment regimen, our algorithm. But I think it can be therapeutic to sort of say, okay, here's a potential reason why you have this. It doesn't mean that it's any less valuable to treat. It doesn't mean that it's in your head, but the nervous system can fundamentally be altered by these types of events. And I think it's artificial in all diseases to sort of see this dividing line between the brain and the rest of the body and say, well, if it's in your head, it's one thing. And if it's in your gut, it's another thing. These are interactive type relationships. They go together. And I'm sure there are IBS-C patients where there are changes that are more in their brain. And there are IBS-C patients that their changes are more in their gut. And most people lie somewhere on that spectrum, which is why there's so many different types of therapies that we have, right? Some that really work on the gut and speed up defecation or make you go to the bathroom more frequently. Others that really work on the brain can all have a role for patients, including multiple agents if they need them.
Oh, no, that's great. Now, when it comes to the challenges and misconceptions in diagnosis, are there any misconceptions about IBS-C that you think providers should be aware of to avoid misdiagnosis?
I mean, I think that the big misconception for me is that when someone is constipated, we sort of say, okay, they're constipated. We put them in this bucket. We need to make them go to the bathroom more often. And I think by virtue of meeting criteria for IBS, if you use them, you know that this patient has pain. And we know that pain, and I would argue bloating as well, are two of the symptoms that patients are really most bothered by. So even though we may focus on speeding up their bowels, and indeed that is part of therapy, we really need to think about, are we concomitantly treating the pain, the bloating, the distension, those other symptoms? IBS-C is not the same disease as CIC. Despite the fact that I said earlier it lives on a spectrum, it doesn't mean that you're necessarily going to make that patient better by exclusively focusing on their bowel habits.
Are there any common challenges that providers are facing when diagnosing IBS-C, especially, I know you mentioned earlier, the overlapping symptoms with other GI conditions, and do you have any insight for your colleagues here?
Yeah, I think, we are a field in medicine of buckets, right? Or silos. We like to say, okay, this is an IBS patient. This is a gastroparesis patient. This is an X patient. And what I tell my patients is that these disorders of gut-brain interaction, they don't respect anatomy, which means a patient who has IBS, where we're focused on the colon, it doesn't preclude or prevent the fact that they could have symptoms after eating or symptoms that are related to functional dyspepsia, which is kind of like an IBS of the stomach, or bloating and distension, which doesn't necessarily fall into any categorization, but actually is what bothers them the most. So I really argue that making a diagnosis is important. It certainly helps with insurance approval for certain medications that are indicated for IBS-C. But at the same time, I always ask a patient, if I had a magic wand, you have these different symptoms, what would you want to get rid of first? What bothers you the most? And sometimes I'm saying, okay, IBS-C, I just need to make them go to the bathroom. Good. Then I ask them this question and they say, oh, you know what? It's the bloating. And I say, I didn't necessarily think that was what was bothering you. So I like to think of treatment for IBS as a menu at a restaurant, right? And I'm the chef. And so I've curated things that I think have evidence base and are not harmful. But at the end of the day, I want my patient, to think about what item on the menu that they want to order, what fits with their conception of what they're comfortable with. That might be a natural therapy. That might be a pharmacotherapy. That might be a brain gut behavioral therapy. And then I want to sort of say, okay, I'm going to push you a little bit and say your symptoms are bad enough that I think you might want to think about this. But at the end of the day, it's a little bit less of a paternalistic relationship, and it's more a sort of collaborative relationship. And then the patient may find that whatever they picked didn't work, but they also know about the other items on the menu that they can try the next time.
What I love about how you explain things, you're great with analogies. And I think this is a great thing for our clinicians to take note of, because it's a really powerful way to convey information to patients in a way that's understandable and accessible. How does an accurate diagnosis of IBS-C directly impact the treatment options that are available for patients? And how do you approach that, and insights for your colleagues?
Yeah, I think once you make an accurate diagnosis of IBS-C, then it opens up the door to say, okay, what are the FDA approved treatment options for IBS-C, right? And there's sort of a limited menu there, right? It is lubiprostone, linaclotide, tenapanor, plecanatide. These are the sort of treatments there that are IBS-C approved. Now, like I said earlier, chronic idiopathic constipation, IBS-C are a spectrum. So you can use some of the treatments that may be only approved for chronic idiopathic constipation, theoretically off-label, but in reality, patients can benefit from both. But also remember that there are a lot of agents that really don't have an established role in IBS-C from a FDA standpoint, but can be beneficial. So, for example, neuromodulators, right? These are agents that turn down the volume on abnormal nerves, things like off-label uses of certain antidepressants. I tell patients these are like training wheels for your nerves. They're going to allow your nerves to learn how to function better, send more normal signals, and then like training wheels, we'll try and take it away and see how you ride without them, okay? Brain gut behavioral therapies, cognitive behavioral therapy, gut hypnotherapy, dietary therapies, right? Interestingly, the dietary therapies didn't have a lot of IBS-C data, but now there is some increasing data out there from the group at University of Michigan showing that there is a benefit of the low FODMAP diet and IBS-C, which I think is something that we've all been doing clinically, but now it's nice to see that there is a bit of an evidence base there. And again, this gets to this idea of a menu that a patient may say, I really want to move forward with dietary therapy. Okay, my job is to connect you with a registered dietitian, because this is not a do-it-yourself project. I want to do brain gut behavioral therapy. Okay, there are apps that are out there. There are clinicians that I know what they're doing, but might have a long wait time. I want to do prescription pharmacotherapy. Okay, these are the options we have. Let's see what's covered by your insurance. So it's really sort of trying to sort out which patient is going to be best for the best intervention. And I always tell patients, in full disclosure, that some of this is a little bit of trial and error. But if we start with things that we know work for at least some proportion of patients, and you're comfortable with it's not just knee-jerk, I give everyone this drug because they have IBS-C, then patients can buy into the process and then can know that there may be 2 or 3 things that they need to try to find the right regimen, but that I'm going to work with them to sort of kind of thread this needle to find the right treatment for them.
And do you ever offer like multidisciplinary approaches, or do you start with one? Like, what is your recommendation to your colleagues?
Yeah, it's a good question. I think for patients who are severe and their quality of life has really been affected in a way where you can feel it talking to that patient, I think multidisciplinary treatments are great. In truth, it's difficult sometimes to make these all line up, right? I'd love for a patient to do a brain gut behavioral therapy, a diet, and a drug and really feel 100% better. Because sort of, they're going to have to wait to find the dietitian. They're going to wait for the brain gut behavioral therapy. There's going to be a prior authorization for the drug. So in reality, many patients, I tell them, we can do more than one of these, and I might suggest pairing these 2 for your particular disease. But the other side of the coin is sometimes I kind of want to know, well, what is working and what's not? Particularly if I'm using multiple drugs, I would prefer to use one drug at a time so that I know if there are any side effects or things like that I have a sense as to what's going on. Because I tell patients, IBS, you are sensitive to what's going on in your gut. You're probably also going to be sensitive to medications. And so throwing more than one medication at an IBS patient may be a recipe for side effects. And then you're not really sure which drug is giving the side effect that you've given. But as I said, a lot of patients could benefit from multiple different things. But I think it's first to sort of meet them where they are and say, well, what did you come in here wanting? Right? Were you really looking for a dietary treatment? One, it's appropriate for you or not. Two, these are the ways that we can make it happen. And then they might say, yeah, but I'm looking for something else at the same time. So we'll do more than one thing. But I think often we're doing one thing for practical reasons.
Makes total sense. Challenging from patient perspective is how do you figure out what specific treatments or therapies are more effective based on the severity or diagnostic findings? And over the years, we've seen the pharmacological products evolve into, they're focusing on different mechanisms of action. And I'm always fascinated by this as a patient. So how do you figure out, and your colleagues, like, what is your recommendation, where do you start a patient, and how do you know that?
I think at the end of the day, the drug that the patient is able to afford, they're willing to take, and they're able to get is probably more effective than any treatment that is my opinion, right? So when it comes to drugs, if you look at the data, there are a variety of different mechanisms out there. There are the secretagogues, there are the retainagogues, there are sort of bread and butter over-the-counter laxatives, which may not specifically treat IBS-C. The data for the IBS-C approved drugs that are out there, there's not a huge difference if we were to look at the individual clinical trials. The net benefit for a given patient, in these big thousand people clinical trials, we can't really say, oh, well, this drug is clearly more effective than this drug. They really are all the same. And that's why I tell patients, it's the one that's covered by insurance that you don't have a particular contraindication to. And I know all of the providers out there, myself included, probably have certain patients that we think might be better for a certain drug. But at the end of the day, we have to acknowledge that there's no evidence that tells us that that's the case. So that's one limitation, is that to say, actually, there's not a good reason why I might use one drug or the other. So often I'm picking the one that they can afford and that they're comfortable with because, for whatever reason, they had a cousin who used it or something like that. When it comes to a brain-gut behavioral therapy, these are patients who really need to acknowledge the role of the brain-gut behavioral axis, right? Stress, anxiety in their symptoms. Someone who doesn't have any belief in that and is really resistant, you don't want to just throw them a prescription or a referral because it's not going to work. And then finally, for dietary therapies, you have to make sure that patient doesn't have any disordered eating, because that's something that can be very harmful if they have a history of disordered eating, which is quite common among IBS patients. And then secondly, that they are willing to make changes in their diet, and that they really need to do that in conjunction with a registered dietitian to make sure that they're, one, doing it correctly, and two, not causing any nutritional problems. So I think it's sort of meeting the patient where they are to find out what do they think can actually work with their life. Because at the end of the day, as I said before, IBS is not going to kill anyone. So we don't need to tell people you have to do this. What we need to do is sort of say, like, what is going to fit with your lifestyle? Because quality of life is what we want to fix. So if the drug works, but if they're spending an exorbitant amount of money to pay for it, well, that's going to affect their quality of life in a different way, and it's not worth it. Or, they're on a diet, but it's so restrictive that they feel like they can't go out, and their, social life revolves around going out to restaurants. These are all things to kind of take in mind. And that's where kind of listening to what the patient really wants out of the consultation. And I always say, what's your goal for seeing me today? Right? You'd be surprised, right? Some people are like, I just want to know that I don't have cancer. Okay, that's easy, but that's something I'm going to focus on. Many other patients might say, I really want to be able to do X, Y, and Z. I want to travel again. I want to ride in a car without looking, for a rest stop because I'm taking a laxative that makes me run to the bathroom. So I think asking patients what they're really looking for can help when I'm guiding the therapy choices.
Now, this kind of goes into my next question regarding shared decision making, right? So how can providers effectively communicate an IBS-C diagnosis to patients who may be frustrated with their symptoms, maybe on that wheel of laxative, abuse, constant taking these laxatives? They're frustrated with their symptoms or the diagnostic process. Maybe they've gone to provider, primary care. And what role does shared decision-making play in this?
I think IBS is the best shared decision-making disease there is. I mean, there's data that suggests that a patient who feels that their provider has listened to them and they like that provider, they feel comfortable with them, they're going to do better with IBS than a patient who, didn't have that. In inflammatory bowel disease, that's probably true to some extent, but at the end of the day, right, you're going to pick a medication that's going to work. You're going to have a surgery if it's needed, and you can hate your doctor, but at the end of the day, it's probably still going to work to some degree. IBS, right, it is really this model, this prototype for shared decision-making. And so the patient feels heard. The patient feels like now, not only do they have a diagnosis, IBS-C, but you've actually explained to them what that means in a physiologic way, this connection between the brain and the gut. And then you're sort of much more able to go into this shared decision-making on a more equal playing field instead of saying, okay, you have IBS, take this drug, call me, in a couple weeks. It really should be, you have IBS. This is what it really means to me. This is why it's a real disease, right? Evaluate or substantiate their feelings, because so many patients have been dismissed by their family and other providers. And then sort of say, this is our menu of options. These are the things that I might recommend. But if you were saying, I don't want to take medication, this may be something where you could try this first, but at least you know of the other options that are out there.
So everyone's always interested in what's coming down the pipeline, and providers, I'm sure, are just as curious. So what advancement in either diagnostic tools, you already mentioned the Rome 5, which sounds so exciting, but are there any other additional tools or research that providers should keep an eye on when diagnosing IBS-C, or maybe some treatment options? Are there new biomarkers or emerging technologies that can improve accuracy? Any insights here?
Yeah, I think biomarkers is something we would love. I think mostly because it would legitimize a diagnosis that we know exists. We know that IBS-C is a diagnosis that merits treatment. Most patients that you diagnose with IBS-C are going to have IBS-C, but a biomarker would make, one, us as providers more confident, and two, make patients feel more legitimized in their disease. I think the microbiome is something where I'm doing some research, as well as many of my colleagues. It is not ready yet for prime time. And it probably won't be ready, depending on who you talk to. This is controversial, right, for some time. But, we know that it's not just the amount of bugs you have, it's who is there, what are they doing metabolically? And as we start to sort of figure out, there may be microbiome biomarkers that we can identify IBS-C. And then the next step, once we sort of say, okay, these bugs hang out in patients with IBS-C, is there something about certain bugs that actually influence the disease course? Because when it comes to bugs, the bugs can either be a marker of the disease, so that's a good biomarker, that's helpful, but they may also be participating in the disease process, right? These bugs are these living organisms, they produce things, various chemical mediators that may trigger nerves that then go up to the brain and can cause these systemic issues. So I think that's the future that's there, but I wouldn't say there's anything immediately in the pike in that field. And there's certainly no brand new drugs that are coming for IBS-C that are in late phase clinical trials, unfortunately. But I would argue we have a lot of good ones already. Some of our own research, which I think is fun to highlight, is we actually did a trial of Tai Chi for patients with IBS-C.
Oh, that's so cool.
And we had a Tai Chi master who worked with us, and this was during COVID, so it was a virtual Tai Chi, so they didn't have to go anywhere. And over 12 weeks of Tai Chi, essentially what we found is that patients had significant improvement in their perception of pain, bloating, abdominal distension, and constipation. And interestingly, bloating is something that is such a bothersome symptom for so many of our patients that we had patients measure the circumference around their waist over the course of the trial. And actually, at their worst, most bloated, many of these patients actually had a decrease in their waist circumference with Tai Chi. Now, normally you would say, well, these are constipated patients. They have IBS. Maybe you just made them go to the bathroom more, and that's why they're smaller. It turned out that we didn't make any change in their bowel habits, right? They were still moving their bowels the same frequency, the same form, but yet their abdominal pain, their bloating, everything improved. And I think this really speaks to the fact that this is a brain-gut type thing. And so, in the same way that a cognitive behavioral therapy or a gut hypnotherapy may be beneficial, I think other things like Tai Chi can be as well. And we worked with the Tai Chi master to really design an IBS-C specific Tai Chi protocol. So stay tuned. We're going to hopefully get some grant funding to look into that more because I think mechanistically it's very fascinating.
It's so fascinating. Doesn't Tai Chi, and I've seen people do it, doesn't that help obviously relieve stress, but also help you have a different perspective on things in life?
Yeah, I mean, I think, right now our attempts to define it in a traditional Western medicine way, we probably still aren't there yet.
Yeah.
But it is a combination of both breathing exercises, meditation, and body movements. And so in some ways, it's sort of multidisciplinary, right? You asked before, does multidisciplinary care matter? Well, you are probably doing stress release. You are probably causing strengthening of the core and changes of the way in your breathing. And you're probably also, doing some other things that are helping this brain gut access. And so actually, one of our interests going forward is actually to investigate what are the mechanisms, right? Patients are interested in this. They really are interested in things that may not necessarily be a drug. How can we say, one, that this is effective, but two, actually start to look at the mechanisms by which it's effective? So sort of take our Western pathophysiology, understanding why things are working, apply it to an Eastern tradition, which has been around much longer than many of our IBS-C treatments, and figure out, can we bring the two together so I can recommend Tai Chi and say, I just think you should do Tai Chi because it'll relieve stress. No, I think you should do Tai Chi because it has certain implications for how your gut works.
That would be amazing. Well, you better keep us posted because this sounds fascinating.
Yeah, I'm really excited about it, and it's just a matter of getting some funding from various sources to try and make it a reality.
Oh, well, I hope it works out. So final takeaways. I mean, this has been such a really powerful conversation. But for healthcare providers listening, what are the top tips you would give to ensure a more accurate diagnosis and better outcomes for patients with IBS-C?
I think the tip that's most important is making a confident, positive diagnosis. Saying, this is IBS-C. I'm confident in the diagnosis. You don't have any alarm symptoms. Let's spend less time talking about what you don't have and more time talking about what you do have. I'm going to explain what's going on with your body, and then I'm going to explain the treatment options. And I think too often we're spending too much time, ruling things out and then left with a diagnosis that says, as I said before, it's just IBS-C. Instead, we make a confident diagnosis. We provide that menu of options, and we spend most of our time talking about the options and how they might work. And I think investing time up front really saves you time as a provider down the road because you create that patient rapport. The patient feels that they've been heard and they trust you. You explain the disease. And now if something doesn't work, which of course it may not, that patient now is your advocate and you're a team moving down the road as you work through various types of treatments to find the one treatment or combination of treatments that works best for them.
Well, thank you. And that approach will go so far with patients because what frustrates them and makes them more stressed out is the constant cycle of not knowing and not, feeling like they're heard. So that's an excellent tip. Dr. Stoller, amazing conversation. I hope this benefits a lot of your clinician colleagues, whether they're in the primary care or the GI or other field. There's some great information here. Thank you so much. And we look forward to having you on again.
Hey.
This has been great. Thank you so much.
Thank you, Jackie. It's an honor to be here, an honor to talk to people about IBS. So thanks for having me.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.